most of glaucoma have it, but not every single one. So that's just something to make a mental note of for the future. So glaucoma usually is an abnormal amount of pressure being exerted in the globe on the optic nerve, which is damaging the optic nerve. It is a very silent disease process, like hypertension, meaning by the time you start to experience any of the problems of glaucoma, you're really in the disease process. So you might start losing peripheral vision, and when that happens, it's because you're late in that process. It's damage the optic nerve, you have loss of retinal ganglion cells, and then you have now visual disturbance. There's two types of glaucoma. We have our primary and our secondary. Primary glaucoma is not from pre-existing ocular deficiencies, where your secondary glaucoma can be attributed to those pre-existing ocular deficiencies. Our type of primary glaucoma, which is what we are going to talk about today, is congenital glaucoma. It's open-angle glaucoma, also known as primary open-angle glaucoma, and closed-angle glaucoma, also known as primary angle closure glaucoma, and then the congenital, which is present at birth. So, where the angle comes from, the whole concept of closed angle, open angle, I thought I should just point this out because I guess until I really started looking at glaucoma, I didn't even know I just said open angle, closed angle. And where those terms come from, it has to do with this angle between the iris and the cornea when you look in someone's eye. And that's where the term comes from. If it is open angle, it is open or normal. And if it's closed, you can clearly see that it's closed. And this is a close-up view of that angle. In this cul-de-sac, this is where all inflow and outflow of all that aqueous humor in your eyeball causing those pressure issues occur. And this is where some of the drugs would work, whether it be on the ciliary muscle, whether it be on some other areas. They will allow an inflow and outflow or a reduction of the aqueous humor. And that's essentially what we're looking at when we look at that little thing. Now, when we're looking at primary open-angle glaucoma, we have normal interior angles. You'll have some changes in the optic disc. We often see peripheral vision loss later in the disease process. Usually, it is elevated intraocular pressure with those normal angles. However, if you have a patient and you look in their eye and they have normal eye pressure, but their optic nerve is changed from one exam to another, then they are actually glaucoma. Just to highlight that not everybody presents with normal pressure, abdomen pressure. So when we are going to start talking about primary angle closure glaucoma, there is an obstruction. Now that we looked at that trabecular network, we can see that when we close that angle, that might interfere with the outflow of aqueous humor, which then would lead to that infection. You can see by looking at that closing that angle would have that effect. And it is associated with elevated intraocular pressure. And then it progresses to acute angle closure crisis, which is actually a very rapid elevated intraocular pressure, which then could lead to blindness very quickly. And those are the cases that require surgical intervention. So that is really some of the telltale angle closure glaucoma. As for the secondary glaucoma, this slide is gratuitous. It's got nothing to do with the test. I just wanted to highlight what they are. Pigmentary, neovascular, traumatic, genetic, steroid, infected, and pseudopolycystic glaucoma. Those are secondary types of glaucoma. We will not discuss. We will not do this test. If you guys are eyeball free, you can look it up. Just get pretty cool to look at. So for all intents and purposes, we're going to talk about open angle and closed angle, which are the most common types of glaucoma. So, because they are the most common, 60.5 million people worldwide are affected by the disease. It's the second leading cause of blindness. And 2020 is speculated that 8 million people worldwide will have it. So therefore, you're going to see it. And if you to work in family practice and as well. As for the open angle portion of it, it's 3 to 5 times more prevalent in African Americans than white Americans. It increases with age. It rarely occurs under the age of 40. 3 to 4.5% of what you think have intraocular pressure elevation. However, 10% of that number will then progress within 5 years of glaucoma. And then almost a quarter of that after 22 years will progress into glaucoma. Those numbers are just for your eyes, not for your memory. As for closed angle glaucoma, there's 15 million estimated to have it, so therefore open angle happens more often. Another 6 million. It's lower in European descent, higher in Chinese, Mexican, and Asian, and it's more prevalent in the Asian female sex. So now that we've talked about this, now that it's what we can do about it, what I do about it, what you do about it, what CA, now you have a general understanding of how glaucoma works, what the meaning is, and what you can do is recognize that it's a silent disease process, and that with silent disease process, we need to screen the value of engagement regularly. Because these changes in vision, like I said, you want to try to identify the patients that are at risk. So what are the risk factors to open angle or closed angle glaucoma? So open angle elevated pressure usually African Hispanic tissue glaucoma over age. Center corneal thickness that actually has an effect on pressure readings too. Type 2 diabetes, low ocular perfusion pressure, myopia. As you can see with angle closure, as I stated, age and female hyperopia, and obviously a shallow inferior chamber with that angle, so that would be good in the history of angle closure glaucoma. So, the American Academy of Ophthalmology recommends adult exams, usually for people around 40 every 2 years. Everybody else older than 40 usually every year. And then if you have lots of risk factors, history of glaucoma, you could be getting eye exams every year. So essentially, that is their general frequency for comprehensive exams. And again, more frequently depending on the risk factors. So now let's talk about the aqueous humor. Really, that's what we need to affect to address glaucoma. So we can modify the formation and outflow of aqueous humor by using drugs. We can affect alpha beta receptors. I want to anhydrate, again, not things I want to do MRI. Because once you understand the general concept, everything else is in the drug class. Because I didn't want to pull up a bunch of slides for you guys and show you the 100 different eye drops. So that's not really useful. That information changes, and that's what the books are for. So my review is going to be primarily talking about some of the drugs, but really going with the drug class. That's the reason. The aqueous humor flows and drains. The whole purpose of an eyeball is to provide oxygen and nutrition to the eye. 80% drains to that trabecular network that I showed you in that diagram. Muscarinic receptor stimulation opens those pores, so that ciliary muscle that I showed you is affected by those muscarinic receptors. We have 20% that drains through the nasal outflow, and that's modulated by the receptors. And again, you guys memorize. Intraocular pressure is dependent on the balance of production and outflow. It's all about maintaining the curvature of that point. So, elevated intraocular pressure greater than 21 millimeters of mercury is considered glaucoma. Degeneration is a slow process, which is why we need to evaluate the pressure pharmacologically. Slow that process down. 40 to 50 millimeters of mercury is associated with rapid nerve damage. So those would be your closure measure that using a device done via phenomenon. And we have those things in the department. Very rarely do we get to use. And talking about that, one of those risk factors for open angle glaucoma is CCT, potential corneal thickness affects factors. So the thicker the cornea, the higher the pressure you're going to get. So that pressure doesn't necessarily correlate to a true elevated pressure. The thinner, it's going to go low. Just something to think about with regards to when you are ever in this situation. Angle closure glaucoma now, that is a mechanical obstruction of that outflow. You can see the angle is closed, so there's an obstruction in the outflow. It could be a pupillary block, which is more common. Abnormalities of the iris, so vision is blocked for an hour to days, and we determine that angle closure by gunstopping. There are anatomical risk factors. And anticholinergic medications can lead to a drive angle closure pupillary block. And actually, both can do it. And those drugs, we will touch upon later, for people that have angle closure glaucoma, don't be giving them Don't be giving them some of the drugs I'm going to talk about later. And these are some of the things you need to think about. If you know you have a patient that has angle closure glaucoma, right? And we're not treating them for that, but yet they come because they have rhinitis or because they have some other issue that you will probably be on. Those are the things that I want you to think about when it comes to prescribing them medication, because then you can affect them. Okay. Also, acute angle closure crisis, obviously, I've already highlighted, is a medical emergency. First, it's going to go probably going to go blind in the next hours to minutes. And you guys are not doing this. However, you need to recognize it. We need to, get steps involved. And only surgical intervention can get drugs do not get angle closure crisis. The only time we use drugs in angle closure is once the pressure, everything's stabilized. Once you know that outflow is now, that process is now working, that's when you start to use once you progress to the media walk. And again, we use the drugs, first generation inhibitions, activity suppressants, psychotics, and all that kind of thing. And you guys can clearly see that those are lots of drugs that probably will be tried for regular. They say lots of people psychotics. They say lots of people take inhibitions. And lots of people want to see what that's in the trial. So there's something to think of when you have your angle closure glaucoma. And so what are our desired outcomes in treating glaucoma? Obviously, we're going to prevent further loss of vision, quality of life, and you want to be able to maintain the intraocular pressure to normal or below normal. That's really our goal. No. These are medications that can make angle closure work. Okay, so antihistamines are anticholinergics. Okay, anticholinergics can theoretically make you retain more water, and theoretically make your eye pressure greater. Same with antipsychotics. These are drugs you need to think about when you have angle closure glaucoma patients, whether you really should be prescribing. I can never tell you that you're never going to be able to do something. That is not the case. Every patient. One of you might be able to find me some angle closure glaucoma that's getting into. However, it doesn't change the fact that you need to think about when you have this. Because, in this world, there are very few absolute 100% patients. It's always that exception to the rule. But I just wanted to expose the generic rather than what we're doing. So these are our desired outcomes. So now we get into the pharmacologic piece. I apologize. This is where I had a refined slide that had a couple extras where I put a header in where it belongs. And this is more of a rough. So I'm getting to the pharmacologic piece now of treating glaucoma. And so I'm going to start with beta-adrenergic blockade. So this is the primary class of agents that we are going to use to treat people with open angle glaucoma or in glaucoma in general when drug therapy is one. So these are some of the agents, Taxol, Cartol, atenolol, placebo, atenolol, and how beta adjuvant blockades work. And what I want you to know is they reduce the aqueous production of the ciliary body. That's what they do. And that's what they do. Okay. It is one of the first line agents. The first line. And it usually results in 20 to 35% reduction in molecular pressure. Most of them are non-selective beta-1, beta-2, except for the Taxol, beta-1 selective. However, the Taxol lowers intraocular pressure to a lesser extent, but it has a neuroprotective mechanism to it. Beta blockers are usually dosed twice a day, and tachyphylactic occurs in 20 to 30% of the patients. So, what does that mean to you guys when I tell you that? This is not a tough question. What does it mean? Yeah, pretty much. So basically, 20 to 50% of these patients are going to actually over time, the drug's not going to work with them. So then what do you think we're going to do with these patients? We're going to add on something different. That's what we're going to do. So the whole point of that is most people glaucoma would take one of the ones. Okay? So tachyphylactic refers to 20 to 50% patients on concurrent systemic beta blockers. There's lots of people on metoprolol and atenolol. Those patients actually have less of an effect when you give them eye drops. And it's obvious, they already have some systemic beta blockers going on. So these eye drops are going to affect them. So they're more likely to actually be combo products. Okay? Any questions?
These are just eye drops, so you have a lesser side effect.
Great question, and we are going to touch upon that in the next couple of slides. So, topical beta blockers have general contraindications. And what I mean by general, if someone has asthma, we're going to do it at home. But I would be remiss not to tell you general contraindications. COPD, cardiac failure, secondary to third degree heart block, because these are patients that you would generally want to give systemic beta blockers to, unless you're closely monitoring. So that leads into your question, which is, do you get systemic absorption from eye drops? Do you think it's possible to go in your eyes? What is the big deal? Actually, it is a big deal, because you have a nasal lacrimal duct that actually drains from your eyes. And these are concentrated beta blockers in your eyeball. It will drain, it can drain down that nasal lacrimal duct into the systemic circulation. And now you have systemic absorption of the beta blocker, even though it's not topical eye drops. The same goes to steroids. The same goes to anything you put in your eye. You can have systemic absorption because of that nasal lacrimal duct from your eye. Okay? So, I'm giving you a picture of a technique that you should teach your patients in general with regards to eye drops. And this is the nasal lacrimal occlusion technique. You put the drops in, you then block the nasal lacrimal duct as you would, like you're watching a lecture that might be stupid. And that would help reduce systemic absorption of the eye. Okay, and that is a technique you should employ with all your eye drops at this time. Because some eye drops don't really have side effects, but I would tell you 75% of them could do it, so why not do it for all of them? Okay? So, now we've talked about beta blocker eye drops. There are lists and tables of every single beta blocker eye drop. They're awesome. In the new book, I can give access to it. My company can devise the table with it. Tells you how many drops, how frequently you do it. I just want you to understand the classes, what's for the line, and then the rest of it, you guys can look in the book to decide which is most appropriate. So the next class we're going to talk about is ocular hypersensitivity, which if any of you have family members or work in retail, have ever worked in a retail pharmacy, you're quite familiar with these drugs, like Canapros, Travel Pros, Nevada Pros. And these work. These ocular sensitive hypersensitivity increase aqueous evil outflow. But however, they affect the trabecular outflow to a lesser extent, even though it does affect it. And remember, 20% of outflow occurs this after. 80% occurs this. So you're basically affecting the aqueous humor from a distance. So you you can see one affected from the trabecular outflow, the other. So you can see how the combo products might be working in with each other. Ocular hypotensive lipids are also first-line therapy in addition to beta blocker therapy. For those patients that absolutely cannot get beta blockers in their eyes because of the you have that moment. You can simply just use it as a primary treatment. It really causes systemic effects, so you don't have to do the beta blocker in the nasal but again, good practice. One thing I do want you to make a note of, so for all you people that love your eye color, or patients that are hanging above their eye color, you can get increased iris pigmentation. Cosmetic changes in the eye. That's something I would want you to remember, because I think that's important. More is not better. We know that with many drugs. So the idea of giving somebody more of something is not better, especially so with the senses. Because actually, giving more of it decreases the benefit. So you should stick with the dosing schedule device. It can worsen anterior uveitis or keratitis. It has been known to cause macular edema. And just for the pharmacy weirdos out there, a can of froze needs to be refrigerated, but once you open it, you can do it untested. Now we'll talk about the next class. For glaucoma. Any questions? No. Alpha adrenergic agonist, aproclonidine and bromonidine. How this particular classification works is they both produce APC production. Okay. However, bromonidine is known to also increase that due to scleral outflow. Aproclonidine, however, is known for tachyphylaxis. So therefore, it's not really used. So you guys probably never been exposed to it, never want to prescribe it anywhere. If you've never met the way you only use these things as like bridge therapy or surgical prevention. And it can also cause blepharoconjunctivitis. Okay. Bromonidine, however, is used in patients with dual mechanism. And it also has the capsule has that neuroprotective effect. And it's usually used as adjunctive therapy. When I say usually, that means you could use it as primary therapy. But more often than not, it's going to be adjunctive therapy. And again, this is an eye drop if you want to counsel the patient on that nasal lacrimal. So those are the two drugs in that sense. So we now have carbonic anhydrase inhibitors. Okay. Very rarely do I see these used. We have brinzolamide, which is topical eye drop. We have dorzalamide, which is topical eye drop. We have acetazolamide and metazolamide. Does anyone know what else acetazolamide is used for in tablet? Anyone like to travel? They actually use it for altitude shifts. So you go, like, if you want to go to like Andes or something, your doctor's going to do that for altitude instead of doing and they reduce APC production of the ciliary gland. And that's how this class of So, the topical eye drops of carbonic anhydrase inhibitors. These are for the patients that cannot use the first line therapy. I've never seen a patient that cannot use the first line therapy. So that's good. They're available, obviously, topical eye drops and systemic agents, so that's part of it. Brinzolamide, the neutral pH, so has less irritation on top of that. The dorzalamide has been reported to cause irreversible case abnormalities have been reported, so therefore another cross you want to divide into what a nasal lacrimal technique so they don't get those drops down. And they are both sulfonamide, so if someone has a sulfur allergy, as with the systemic carbonic anhydrase inhibitors, you don't want to use them, but I would be remiss not to talk about it. Acetazolamide, metazolamide, and I threw the dichlorphenamide on here because it is one. I just put it up there just so you can see it and know the reasons for each tolerated. These are third or fourth lines, and you take a terrible side effect. And again, we use them in bridge therapy. So this isn't really good average
diamops for
acetazolamide.
acetazolamide.
Diamond.
Yeah. Do they use that in like an intravenous form? If someone comes to the ER, they get that because they have this acute closure.
The acute closure, no, because acute closure is a surgical required surgical intervention. There's some sort of blockage. Usually with acute closure. We're not going to treat acute closure crisis with a drug that we're going to get that shot up under control. Okay, so this might be something they deem as worthy when they're trying to get surgery. But initially, that's not really a therapy. And that's probably one of the deal with alcohol. So these are systemic awareness and anti-considered adverse effects. As you can see, they're powerful. Right? But you can see they're not fun. Particularly if you do all that. And again, it's not one of them. So, now we're going to move on to pulmonary disease. It is the third line treatment. Carbachol and pyrocarditis. This actually is the very first class medication ever invented. But it is the third line treatment. The olive tree biggest house farm is special medicine. And that's how they work. And so I want you guys to know that when I give up class questions, I am not going to ask you which drug I want to use. So I just want you to know that. And that's just, I can be here 3 hours if I just put up every single thing. You know, what class would we use, if this didn't work, together, everything. So, meiosis refers to excessive pupil dilation. I don't know if all of you know what meiosis is, and if you don't, it's a concept you should know. Because it's important. So, is this true or false? Anyone think it's true? One of you. Of course, it's false. So, mud dryness is pupil meiosis. And that concept will be related to as you look at people with these drugs, which is opioids, which is that. That's one of the concepts. So, move on to the next slide. Excuse me, still talking about pulmonary disease. They're also known as myotics. They cause excessive pupil constriction. It comes from the ancient Greek. It is the first population ever invented, but again, a third line, fourth line treatment. Invented, however, it's the third, fourth line. We divide it into direct acting and indirect. They stimulate that muscular receptor and then constrict that ciliary muscle. I don't know if you guys remember from the original diagram I showed you, which then opens the pores which allow it to open. We would want to delay the use of pilocarpine, the nasal-occlusive glaucoma, until the intraocular pressure is not under control. I added that on the updated slide, that which will get the LCO. Again, it's contracted ciliary muscle. It can displace the lens forward. So we want to avoid it with severe myopia because it can cause myopia. And I don't expect you to memorize it. You're not going to become ophthalmologist. Most of the why you don't use pilocarpine in so carbachol is the other thing. You never use it, rarely use it. If you hit a pupil and that's great, it can cause corneal clouding. And now it's indirect alcohol. Okay. So carbachol kind of crosses over into the indirect pulmonary disease because it also inhibits the pupil. never in my life ever seen engagement structure, but I'm going to talk about this. Indirect acting co-initiation, I can't pronounce it. Echo, COP, Deuterium bromide, both inhibit gluconesterase receptor, which then again can affect activity. We discontinue 1 week prior to surgery. Why would we do that? Why would we need to discontinue these kind of eye drops 1 week prior to surgery? Toby, why would we do that? Bueller? Bueller?
He doesn't know my last name.
Okay. So, one of the agents that is used in surgery are neuromuscular blockades. Okay? So, if we're inhibiting acetylcholinesterase, we are essentially inhibiting this person's ability, essentially, to metabolize those neuromuscular blockades, which would keep them paralyzed longer. Right? Come on, that's interesting. I just made an eye drop. So whenever you hear the word acetylcholinesterase, and that is the relationship between eye drops and surgery. Right? And that's why we want to do this. That's not unusual. Now we get into agents that will never be used. But I'm going to talk about that. Hyperosmotic agents. Glycerin, isosorbate, and mannitol. The only time I've ever seen mannitol used is medicated to treat cerebral disease. Okay. However, it could be used for glaucoma because it increases these agents increase the osmolality of the blood, which then therefore, like you can see in the brain, dehydrate your eyeball, as we would hope it would dehydrate your brain. So, glycerin and isosorbate are taken orally, mannitol and IV. Why is that? Has anyone ever seen mannitol? Out of curiosity, yeah. It looks like, you ever look at a vial of mannitol? Gigantic crystals on that. That's not fun for your brain. So in your practice, as a side note, if you ever help them see the kinetic as a PA, if you come, make sure you fill your name. Okay? You know we can talk about that. And isosorbate is for diabetics, because we're not going to diabetics. These agents should be used in toxic cases of renal, cardiovascular, obviously isosorbate. Problems, but I can promise you, you will never see this in your career. Cutting edge ophthalmology. So now we get into non-selective adjuvant agents. Epinephrine is one, and it works by increasing the outflow of ACE. And I corrected this. Okay. Is the last line that you would ever use. It has, again, a lot of side profile. It increases corneal penetration. And so, because the epinephrine just has that corneal area, it then gets squeezed into epinephrine. And then that epinephrine has alpha and beta in its state of activity, which I discussed in the very beginning of the lecture. That will affect hormone. Exacting or narrow angle closure, you want to avoid it. This means no lens. They have no lens. So, I thought everybody wants to know, and so I could put this in there, it's not in your book, but I figured somebody wants to know. So, smoking marijuana is a recommended effective stage of notification for glaucoma. Hey man, I need for my glaucoma. Oh yes, I'm 420. Is it? I mean, is it true? I mean, we got all these marijuana things popping up everywhere. And I'm not for or against it. I'm just asking a fair question because we all know that that's what I got the glaucoma. I would like the African jumbo elephant special. So, is it true? Could be. I mean, people get medical cards for it. Anyone? Oh. Right, so it is fall. So now, when all your patients want you to, when it becomes legal in Florida, and they ask you for their hydroponic prescription, you have two choices. You can voice, or you can approach evidence-based approach. At this moment, although marijuana can affect intraocular pressure and lower it, it's true. You actually have to smoke every 2 hours. Dog
But isn't some of the oral preparations like they're some food stronger and can probably be
great question. So we're talking about brownies or whatever. I mean, I don't know. I'm old. Red Bull and vodka. That was my I've never had a power. Red Bull vodka. Still available in Japan, so don't laugh. Love it in Japan. Viva is it's like a malt liquor, I believe. But it has 90%. But they love it. Alcohol espresso. Yeah, it's alcohol espresso. I'm glad I can take that. And also, we can never forget that smoking marijuana has other consequences. There's like 400 other compounds. Right? And so you can't negate the risk factors of smoking marijuana. But at this time, there's no evidence base for the treatment of glaucoma with marijuana. Don't ask if you want to know. Oral marijuana has not been proven to be beneficial. They have been unable to create eye drops, but I'm sure they're working on it. With the 10 eye patch. So at this moment, no marijuana. So now we're going to get away from glaucoma. Any questions about glaucoma? Yes.
So we give beta blockers, yet we're giving a drug that's going to turn into epinephrine. I know it's an alpha agonist, but beta as well.
Well, the thing is, again, those are third or fourth line agents used in other agents not working. And it's all about affecting from the first slide. Affecting that's how we can affect the flow and production of agents by all those means. So primarily we want to affect it via the beta, right? But that affects the muscarinic receptors that would open the ciliary muscle. Hopefully.
Would it be used more than one versus the other?
To be honest with you, you really wouldn't use it. I mean, these agents are older. We've gotten away from them to be a better treatment. But I mean, I'd be remiss not to mention, like I said, a lot of those older third-line, fourth-line agents, you guys will never probably ever see them being used unless you're in some sort of surgery center or you have a patient who's using it out of work. And it's like that, those are the Hail Mary drugs. I've never seen a school that you could roll out for glaucoma. However, and I didn't even know you could use it for glaucoma. That was just something you didn't go like in summer. Any other questions about glaucoma? No. Okay. So you guys can look at charts of the names, like beta blocker drugs. There's awesome charts out there. I just didn't want to over one. The slides were already long enough. I don't want to add one more slide. What which data longer or what's important to the time of work, what you know to start with, what you need to add on to, you all know what you do with angle closure glaucoma crisis. Give drugs. Yeah. How quickly can they go blind? Right, that's what you need to know. Right? What's the first line of treatment for open angle glaucoma? They lost it, right? That's stuff you guys should know. Rest of these down in the book. So I'm going to move on to corneal abrasions, which is no more questions about beta blockers. So there's 5 layers to the cornea, and basically we'll solve to that. The cornea contains no blood vessels, it's nourished by tears, oxygen, and the humor. In moderate abrasions require 24 to 72 hours of healing. That's not really, you know, you got to tell a patient, it's very common. I don't know if any of you wear contacts. No? I do, and I had to stop wearing but I never did. And I got it. Corneal abrasion treatment, complete healing with no scarring, no surgery. We want to prevent infection, pain, and corneal loss. These are the outcomes we want. So, what do we start with when we treat corneal abrasion? We can use non-sterile anti-inflammatories, non-sterile topical medicines. They make anti-inflammatories. These are the items. Pharm, we use caution with patients with clot disorders. Again, oral analgesics have not been studied. However, for the people that have 4 diagrams, we might be at I think that I'll evidence it for this, but we're not going to use anything at all. The treatment of corneal abrasions, prophylactic topical antibiotics. We want broad spectrum treatment. That was something I had to do. Infection, and the point is that it will get infected with and obviously we want the individual to do contact with the glasses on. And if they do wear contacts, we want to cover the pseudomonas. That's what we were about, pseudomonas. Okay. And for those of you who give gentamicin or and we don't cover the eye. That's what we want to do. Okay. And that is pretty much how we do it. And if they don't get better in 3 to 4 days, what do you do? You're going to reassess the foreign body. And then you obviously find yourself. Because it's your healing too. Ophthalmic sort of continued traumatic injury. So we're just going to gently irrigate that. Remove whatever foreign body is. And then if you're unsuccessful in irrigating the foreign body out, you're going to do consult. So psychoplegic, trachectomide for pain. So those are actually undidriatic. Okay? They open up the eye and take a little bit of pressure off the eye. You have to use extreme caution solvent when you use these. And any traumatic injury we want to do an eye shield up. And splash injury, chemical exposure, they irrigate the eye for 15 minutes. Let's 5 years old. You know, you can't just do a little bit of contact on the a couple of minutes. And you make it go snap over your eye. Okay, over your eyeball. Very uncomfortable. But basically, splash and chemical exposure is really uncomfortable. And that's essentially how we see that. No, let's get the ophthalmic disorders don't like. We have bacterial, we have viral, and then we have hypersensitivity to pollen and other allergens and that sort. And this is probably what you guys do a lot of. So what are the differences? So we obviously want to resolve their problem. We want to preserve their eye function. We want to prevent any adverse problems with the eye in the future. We want to leave the ophthalmic we know how the pages are. So, how can you tell the difference between the 3? Right? I can honestly tell you that this is so rare. We like to think that everything is bacterial. This is not true. This is very rare to see bacterial. I've talked to ophthalmologists, and they say they seem like a few. majority are not there. Obviously, the staphylococcus or more okay, these are gram positive. It could be hemophilus influenza gram negative. So largely empiric coverage with immediate coverage staphylococcus. These are the tables referencing the new optional book. And I just looked at it there. All these stuff. Polymyxin B, trimethoprim, or erythromycin phosphate. That's the first time. Right? Aminoglycosides are alternatives, but they don't really cover gram positive. And then if we have recurrent eye infections, you feel that we can continue to treat them, refer out, then we would use fluoroquinolone. But they would never be a first-line agent because they have terrible strep toxins. So the first-line agent is polymyxin B trimethoprim. Second-line fluoroquinolone. So viral conjunctivitis. This is what pink eye is. Pink eye is not bacterial, it's viral. Women, swimmer's eye. Try to swim pool. It often presents with upper respiratory infection. So think about all the things you've ever been sick and just right? These are the majority of these things. They're self-limiting, so we don't give pharmacologic therapy, right? And that's an important point. Because if you guys are giving erythromycin to everybody, what's the problem? What's the happen? Resistance, right? You guys are thinking microbial stewards too. And even sending stewards things, like, no, that is not the way it works. We need to get on infection. In a broad spectrum, it will not work. So think of it with this. You do not treat viral conjunctivitis. It's self-limiting, it should be all on its own. We avoid close. So these are the important things to do. Avoid close contact with other people, don't be rubbing your eyeballs. We avoid swimming because that's one vector. We wash our hands. And the virus is viral. And that is what's viral. Right? Goo, that's good. That's a lot of it. So, allergic conjunctivitis. Allergic conjunctivitis. It's a very broad term. Often patients have a history of some sort of other allergy, season going on, other allergic conditions, maybe they have a history of eczema, asthma. They have some sort of allergic problem. Like from mast cell granulation, itching, swelling. And then you have conjunctivitis, anything know what that means? I think Cody remembers. He had a cat who now is paramedic. And he always has these red eyes. He'd be like, hey man, what are you doing? Right? Always red eyes. And he used eye drops all the time. And that's the thing. It is this idiosyncratic event that occurs where I get used to it and then you can never stop it. It happens when you use nasal spray. We'll talk about what it means in the time. And that's what that means. It's caused by the medication. So the treatment revolves around slowing or stopping the allergic process. So the first line of therapy is wash the allergen away from the eye. It's the first line. Our typical is wash the allergen. Right? We're going to do a stepwise approach. These tables reference the histamine. So you might want to look at out on the test. Second line should be antihistamine. The difference between first generation antihistamine and second generation antihistamine is all what is the difference? I don't know. Right. Second generation or less. Third line are mast cell stabilizers, possible NSAIDs, lastly, corticosteroids and immunotherapy. But it is the last one. So, a mass bacterial parasite caused by fungus is caused amoeba and amoeba parasitis. Forms up. Some ways to cause it is on staff stress. And if they were in contact, definitely it causes scars and oxygen. So is this something we should be treating? I want you to remember this. No. All cases require consultation. If you get someone bacterial parasitis, you've heard. But down the realm of treating it, you would start with topical antibiotics, fluoroquinolone, our effective combination therapy. The least amount of resistance you will see with toxicology in the alcohol. And actually, I've been exposed to this because I used to have this compound patients. Sometimes we have patients that we have to compound such as eye injections from the stuff that we give intravenously. So this actually happens. And I've had to compound fortified antibiotics, packing it for themselves and ophthalmology to the point of the eye. So it's definitely something that happens. Definitely something that requires a high level. In some cases, you want to give them topical corticosteroids to treat inflammation. And the only time we use those fortified antibiotics is when they're not responding to traditional antibiotics. So that's when you use it. So we don't want to. That's what you have to do that. That's all. Any questions about bacterial parasites? No. So now we're going to talk about macula, age-related macula. It's deterioration of the macula. Prevalence increases with age. We don't know why it happens. There are no approved pharmacological agents to treat it. There are some drugs that they're looking into. There is no cure for it. So really our goal is to slow the disease. That is what our goal is. So how would we do that? That's what we help you stop smoking. Okay, and I had risk factors in that situation. I will go over with you right now. So, age. And some related ones. Obesity. High fat intake. Low vitamin. Related to this. There was an age-related study, which again, you all probably know people in the that it showed a slow progression of disease. However, there really was no clear statistical benefit shown. And something to keep in mind, beta-carotene, a risk factor of smoking, correct? Beta-carotene has been shown in smokers. So, vitamins actually aren't always good. All you vitamins are very, generally speaking, there have been studies to show that people that take vitamins really have you should have some deficiency. So since there is no clear benefit and they are not without risk, I say why do that. So dry eye. Added more to the dry eye. Dry eye is so boring. I can say three things about it. Dry eye. Maybe caused by urine secretion or pure evaporation. It's dysfunctional clear syndrome. And I added other names for it. It's inflammatory. It's called keratoconjunctivitis sicca. And that will be on the updated slide. It is not on the tab. And that is the functional cure that occurs. Okay? So what we do for dry eye? Cyclosporin, they don't know why it works. They feel it has some immunomodulating effect. So cyclosporin is a prescription eye drop made for that. And then we can take oral cholinergic pilocarpine and the bismol. So anyone know what Sjogren's syndrome is? Dry eye, dry mouth. That's it. And so those are the people who are getting disease. Their dry eye is going to be pretty bad. Let's talk about cholinergic. What does that mean? Anticholinergic means this with cholinergic makes you what? It makes you nauseous, it makes your mouth water, eyes water, and cholinergic. So that's how much is the overuse of antibiotics because of the pain or photophobia that's only involved in and then refer. And then if your patient's not getting better in the whole week, you need to put them on one involved. Corneal rate is involved with it. Those on the pearl. And you get.
Oh.
Yeah.